All right, so intestinal disorders. So this is our second section. Our last section will be inflammatory disorders, but we're going to be talking about kind of some extraneous things. We're talking about hernias, okay, hemorrhoids all the way at the end over here, all right, so hemorrhoids. We'll talk about diverticulitis versus diverticulosis. You want to be able to differentiate those two. And then, of course, at the very end, we've got colon cancer. The whole colon can get cancerous, and you can bet alcohol and smoking's on there, but also there's a few other things to talk about with colon cancer. And then if you have diverticulitis and you have complications of diverticulitis, you have complications of a hernia, you have complications of colon cancer, you can get a colostomy, right? It's where they take out some of the bowel and then attach it to your abdominal wall until you heal. Okay, we'll talk about that. All right, so hemorrhoids, diverticuli, and hernias. And we're going to come back to increased intra-abdominal pressure because it causes this one, it causes this one, it causes this one. It causes a lot of problems when you have increased intra-abdominal pressure. All right, so what is this? Oh, this is how you feel right now, I think. All right, intestinal disorders. All right, so hernias. So hernias are, again, increased intra-abdominal pressure. A hernia is just anything that has gone from one place to where it shouldn't be, right? So what are you doing here, right? So hernia is going from abdominal cavity through the hiatus. That's a hiatal hernia. So technically, you could talk about hiatal hernias here too, but it's increased intra-abdominal pressure pushing things out through a weak spot. So when we have kids, meaning females have kids, then you're going to have a weak rectus abdominis, right? It's going to have your risk for a hernia through that weak spot, right? Men already have a built-in weakness in their inguinal region. Much more common in men to have a hernia through the inguinal canal. There's such thing as a femoral hernia as well, which is nearby. And then we have umbilical hernia. It's pretty common. That's where things push through the umbilicus, usually with age, right? With obesity, because remember, obesity and fats around the hiatal hernia made it weak. You're going to make it weak around other areas as well, right? So what causes hernias? Increased intra-abdominal pressure. So we have increased intra-abdominal pressure, the same thing as before, right? We are straining, we are lifting heavy objects, we got sudden twists, pulls, muscle strains, obesity, pregnancy, chronic cough. All these things are increasing our intra-abdominal pressure. And guess what? They did it in, 1500 BC as well, right? It's the oldest known affliction of man. So you see this guy right here reducing a inguinal hernia. All right, he's pushing it back to where it belongs, right? And I don't think it worked. He died later, and he's still there. It's like, great job. All right. Anyways, we have weakened muscles, right? So weakened muscles or increased intra-abdominal pressure, or we have weakened connective tissue. And because for the same reason we have decreased wound healing. Why would you have decreased wound healing? You're on steroids, right? You're diabetic, you're malnourished, you're a smoker. All these things are going to reduce collagen production, reduce wound healing, and of course that could cause hernia in the first place. But also, what if you have a midline incision post-surgery and you have all those things? That midline incision is not going to heal great, and you get a high risk for herniating through that incision. Okay. And of course, if you have an infection or abscess in those areas, that's also going to make that area weak, right? It's going to be taken over by the hematoma or taken over by the abscess, and it's not going to heal great. Okay. So what else? So these are the causes of hernias. Right? It's about 700,000 repairs annually. They're describing the same thing, right? So we have a increase in pressure. All these things are causing our bowel contents to go through a weakened spot of our muscle or connective tissue. So it's going out. Okay. Sometimes you just push it right back in, just push it back in, and you're golden, right? But sometimes it's annoying, and every time you sneeze, right, you get a hernia. So it's not great, right? You want to try to fix that overall, right? You're not going to get the ladies with that. Anyways, what else? Okay, so these are all the different symptoms we'll talk about next that you get from that hernia extruding, right? You're going to get some dull pain there. And the pain is going to escalate really quickly as soon as that starts getting strangulated. Like we talk about the hiatal hernia, it can twist and get strangulated, right? It's the same thing can happen here. All right, so abdominal types of hernias. All right, so we have abdominal, we talk about go through the umbilicus, it can go through the ventral, which is the front of the abdomen, right, which is an incisional hernia. All right, so previous surgery or inadequate wound healing, who doesn't heal great? We got smokers, we got someone who dehisced, right? Like, is that like an opposite of what a cat does? No, I'm kidding. Anyways, you got immunosuppression, and then if incisions are higher than the umbilicus, usually it's more risk. Anyways, we got groin types. If it's not abdominal, it might be groin, or it could be inguinal or femoral, right? So what else about femoral? So usually, if it is femoral, it's actually pretty serious. It can actually accelerate to a incarcerated or a strangulated hernia. Okay, so what are the symptoms of these? We talked about hiatal already, right? Inguinal is in the groin. That's the one that can be hopefully reduced. We just push it right back up. And there's a huge canal, it's a direct conduit to the bowel contents. And if it's below that conduit, it's technically called a femoral hernia. Okay, so strangulation and incarceration are worst case scenarios. Those are scenarios where you need surgery to come in. And how do you know they need to come in at 2 in the morning? You have to assess them and say they have X, Y, and Z symptoms, right? So otherwise, they're going to have normal symptoms of increased pain, dull pain, right? Especially with sneezing and other increases in intra-abdominal pressure. But when it's escalated from there, the pain is immense, and they might even have vomiting, or they start getting redness in the area and ulceration in the area, and you can see a change in color. That's not good. Okay, so signs and symptoms. So you can see this hernia they went to surgery, obviously, or this wasn't at the bedside. And then we have a hernia on the left there, which is much, much darker. It's ischemic because it was strangulated. Okay, strangulation, if you strangle somebody, they lose oxygen supply to the brain, right? So it's the same kind of deal, right? We are strangulating the hernia. The hernia itself is not getting a good blood supply, right? Sometimes it can just pop out, and then like this guy, just pops right back in, just push it right back in, and you're good to go. Okay, that's called reducible. Irreducible means it pops out, you can't put it back in, but it's not strangulated yet. It's outside the body, and it can't go back in, but it's not turning red, it's not ulcerating, it's not causing immense abdominal pain, right? It's not causing fever-like symptoms and a lactate elevation and an infection, right? So it's causing, or like infection-like symptoms, where they have tachycardia, tachypnea, and they are getting really, really agitated, and they're showing signs of tissue death. That's not to that point yet. Okay, so there's a little mnemonic here, right? So strangulated is obviously the worst one. Incarcerated means what? It's trying to get back in, but it can't. It's been incarcerated outside the body. Okay, and then what else? So one of the things they can do at the bedside, they can push it back in. They just grab it and just get a little pop, and then try to push it back in. It's like a ghost moment, right? Trying to push that guy back in. Right, let me reduce your hernia for you. Maybe it is attractive when you sneeze out your... All right, anyways, you have this guy up top has a significant hernia, right? And then here's another example of an incisional hernia here. So he has a wound that didn't heal great. Might be a smoker. Diabetic, all the above, on steroids. You can see the peristalsis there. He's like, I'm going to try to reduce it. All right, so that's a incisional hernia. There's a ventral hernia. All right, so one up top right, I think is a better picture of ventral hernia. Actually more umbilical hernia than anything else. Okay, so those are examples of hernias. And what's the worst one? the strangulated one. All right, how do you fix it? Oh, what happened? Okay, there it goes. All right, so how do you fix a hernia? Surgical is really the only thing you can do. If you can't afford surgery, or you're not a great candidate for surgery, you have like heart issues, you're not in a great position, you can have little belts that will support the hernia, right? Either up top, or you got an inguinal hernia support. They're called trusses, right? So a truss or a binder to reduce the hernia to prevent it from leaving, right? And that guy before is like, please wear your truss. I don't want to see that anymore, all right? So you do a hernia repair. And the hernia repair is where they open it up and they cut, they manipulate the bowel and they push it back in and they sew it all back together so that it doesn't come back out. Whereas the hernioplex, right, that's what it's called, hernioplasty, is where they open it up and they just put a mesh on there. It's almost like an abdominal binder underneath your skin, right? So they're just putting a mesh there to prevent it from popping out. Obviously, you're going to recover a lot easier from just a mesh place versus your muscles sewn together and your bowel manipulated, okay? They might have to do a bowel resection in this one. That's when someone has incarcerated or strangulated hernia. They might have to take out the bowel, cut it, and anastomose it. What does it mean to anastomose? It means to sew it together, right? Like when you go to grandma's house, she's anastomosing a sweater for you. Okay? Can you anastomose my jeans? I ripped them outside. Anyways, post-op, all right? So they got to avoid coughing. That's what caused it in the first place. They should be splinting, okay? They shouldn't be lifting more than 10 pounds, right? Avoid constipation. How do you avoid constipation? Squatty potty, is that what you said? All right. So yeah, avoid constipation, high fiber. They're going to do what else? Increase liquids. They could use a stool softener. These are all things to avoid this hernia from exiting the body. Okay. All right, so hemorrhoids. So hemorrhoids are also due to increased intra-abdominal pressure, right? So we have an outpouching we're basically herniating a blood vessel at this point. The blood vessel makes its way out of its housing, right, the anus, and it gets trapped, right? You sphincter it shut because you're like, oh, I got an exam tomorrow, right? And then now you got extra pain, okay? So that increased intra-abdominal pressure due to constipation or due to heavy lifting, due to standing, portal hypertension we'll talk about next week, but its increased intra-abdominal pressure is going to push this hemorrhoid out. You have what are called internal hemorrhoids and external hemorrhoids. Basically, there's teeth in your anus, all right? It's called a dentate line, right? So that's what distinguishes external versus internal. Usually internal hemorrhoids just cause like itching. They're not really that bad, but they can progress and get bigger and bigger and bigger, and they can then make their way out and get pinched, right? And that's what causes pain. It's called a grade 3 or grade 4 hemorrhoid, okay? So there's 4 centimeters of anus, and there's a dentate line in the middle, and then you can separate internal versus external, okay? What else? What are some hemorrhoid journeys out there? They can prolapse and protrude, or they can just stay where they're at. If they just stay where they're at, it might just be itchy, uncomfortable, but because there's like mucus and stool that get in there, it's getting itchy. Or it can do what? Just peak, right? That's second degree, right? Not an AV block, but it just peaks out and it might go back in. It's reducible. It's a reducible hernia. It's not going to be like a ghost situation, but it's going to go right back in, okay? And then it can get strangulated, just like a hernia. It gets strangulated, gets prolapsed and trapped by the anal sphincter, right? And basically it gets thrombosed, and when it's out there, and that thrombosis causes localized inflammation and irritation, and that's really where the pain's at. Okay, so how do we avoid this? Hold, please. There we go. Anyways, I was trying to play the squatty potty, but it didn't play. Anyways, we have what else? We have hemorrhoid symptoms. All right, so 40% of them are asymptomatic, right? I'm probably the last time you'll see buttholes. So 40% are asymptomatic, all right, painless, bright red blood per rectum. It's usually just like it's with wiping, right? So the wiping, that's where you get the pain, or they might get pain, but it's just blood on tissue. It's not like constant blood. Okay. Again, we said internal was itching, with irritation. They might have to use an anoscope. There's an anoscope down here, right? So it's less in length than the other proctoscopes and what's the other one, rectoscopes. All right. Anyways, these guys are to look. The doctor can look in there and they can see if there is hemorrhoids or not. Right. They can see if they can reduce it or not, and if they need to, if it's really causing problems, the ones that cause problems are usually the grade 4s. It's never a medical emergency. Like you really shouldn't be going to ER for a hemorrhoid. It's never an emergency, but it's very uncomfortable, and they need to get management of their. They want management of their hemorrhoids. Okay, so that's the grade 4. So let's see if this works. To unselect and press play. I'm trying to press play on these videos. They're not wanting to play. Maybe it wants to be plugged in. Let's give it a sec. There we go. So that's how you treat them. All right, here's the different examples of it, right? You can go in there and usually cut out one that is causing a lot of problems. I think this is the one we talk about the treatment.
Hemorrhoids. To snip or not to snip? That is the question. They've been your butt mates for a long time, but they ain't paying rent and they ain't going away anytime soon. You're relying on sitz baths to soak in them and bidets to hose them down. Cleaning between those nooks and crannies is a high-maintenance nightmare. Nothing seems to be working and you're at your wit's end. You really want them removed. But wait a second. Surgery ain't cheap, fast, or painless. Afterwards, you'll have an open wound in your anus that'll take a while to heal. It's gonna hurt like hell to poop, and you're gonna need painkillers for recovery. If you neglect lifestyle changes like good diet and proper pooping technique, you may cause even more hemorrhoids to grow. So have a good talk with your colorectal doctor and explore your options.
All right, so sitz baths are a non-pharmacological way we can help them. Now, usually after a sitz bath, they're looking like this. But we have what are called astringents. We have things that can help your the irritation, drying up drying up with like topical. It's called astringents, calamine lotion, zinc lotion, witch hazel. Right. So these are some of the examples too.
Itchy butt, weepy butt, leaky butt. Everyone needs a helping hand when they're in a butt crisis. So let me share some of my favorite butt creams for my butt wrap. Start with the witch hazel wipes to cool it all down. This natural anti-inflammatory can help with irritation and can shrink your hemorrhoids. Preparation H for the pain outbound. It has hydrocortisone and lidocaine that reduce inflammation and pain. I like zinc oxide for the healing compound, restoring the anal tissue and alleviating that rawness. I use Aquaphor for walking around town. The thick texture reduces chafing and stays on all day. Balinol balances pH out with lanolin. It's a skin cleanser that's great for sensitive areas like your body. Remember, these medicated butt creams are meant to be used during flare-ups and not all the time. Adopt healthy gut habits and your butt will be wrapping too.
All right, so these are different medications we can use topically. All right, we have non-pharm. That's where you're decreasing intra-abdominal pressure, you're decreasing constipation by increasing fiber and fluids. But eventually, if it's a grade 4, not murmur, but grade 4, it might murmur, I don't know. But you're going to do rubber band ligation, where they just kind of suck it up right here, right? And they're going to put a little rubber band like you do, like their daughter, and you just put a little vacuum to it, and you just put the hair tie over it, right? That's exactly what they're doing, right? It's not much technique to it. They just vacuum it up and they put a little hair tie over it, and then it scleroses on its own. If not, they can inject a sclerosing agent, which hurts like hell. They just inject, I think it's like liquid nitrogen actually, into it to try to. It's called sclerotherapy, cryosurgery, and that's not recommended. That's going to hurt a lot, where they freeze it off. Okay, and they can do a hemorrhoidectomy, where they go in and they just take off the hemorrhoid, where they resect it. They go in there and they take off the thrombosed hemorrhoid, right? They can do a sigmoidoscopy at the same time. If they start having alarm symptoms, they start having weight change, unexpected weight changes, they have a persistent GI bleed. So we have to be cautious of that still. Okay. And usually the complications after surgery is just fearful defecation, which can lead to more hemorrhoids, ironically. All right. So diverticulitis. So we'll do diverticulitis, diverticulosis. We'll take a break. So diverticulitis, losis. You want to be able to differentiate these two. So we're coming down here. Where's my black marker at? I lost it. There it is. All right. So we've gone down through the intestines. All right. The small intestine to the large intestine to the anus down here, where we just had a stop at the anus. We had hemorrhoids, right? And then we had herniation right here, right? We had hernias. And then now we're in this region right here. We're talking about diverticulitis versus diverticulosis, right? So diverticulitis, diverticulosis. So what's the difference? One is an itis, one's an osis. So what does itis mean to you? It means inflammation, right? So it's infections only if you have like a white count elevation, everything too, which this one sometimes does. But it's inflammation of the diverticula. So what's a diverticula? It's a hernia. It's a hemorrhoid of the sigmoid, basically, right? So you can see here's our little toy right here. Next year I'll buy some on Amazon, but you've seen these before, right? The dollar store. You squeeze it and it outpouches. And why does it outpouch? Because you had increased what? Intra-abdominal pressure, right? So this duodenum, this diverticulitis and whatnot. Anyways, this is the smallest part of the colon, right? So it was larger proximal to the sigmoid colon. So it's a really small bottleneck, basically, right? And then now you have all this increased pressure behind it with the constipation, with absent squatty potty use, and you're squeezing. And what's going to happen? It's going to pop out, right? So you get a little poppage going on. It doesn't make any sound, but it's going to cause a little outpouching of the sigmoid colon. That's where it's most commonly found because that is the smallest lumen, right? It's like a literal bottleneck that you're trying to squeeze all that stuff through, okay? So the diverticulum is a little pouch, and that little diverticulum, this little outpouching, can get inflamed, or it can just stretch and bleed, right? So if it stretches and bleeds, it's called diverticulosis. Diverticulosis is associated with bleeding, whereas diverticulitis is associated with infection and perforation and fistulae. What's a fistula? It's a connection where there should not be a connection, right? So you have a connection between the duodenum, I keep saying duodenum, between the sigmoid colon and the bladder, right? What's Greek for bladder? What's that? Cysto, yeah. It's also vesico, right? So you have a entrovesical fistula, right? Or you have an entero fistula. What is that? Nope. Entero. That's bowel to bowel. It's made of fistula, right? There's enterovaginal, there's enterovesical, there's entero, there's enteroperitoneal fistulas. Basically, you have a direct conduit to where it shouldn't be. So you're going to start getting infections real quick, right? So going back up top, so diverticulum is that outpouching. You have this increased pressure that's pushing it out, constipation, straining, low fiber diets. And so those are the risk factors, obviously, but obesity puts it more at risk. Smoking makes your stuff weak, right? Western diet we talked about. And what else? We have meds like NSAIDs, steroids, opiates put you at risk for constipation, right? Steroids put you at risk for collagen breakdown and such. And then we have this outpouching. And this outpouching is a perfect spot for my painted rocks, right? It's called a fecalith, right? Lith being stone, feco being fecal, right? So it's literally a poop rock that catches in there. It's all the little things that you may collect over time. And it's going to collect in there. It's going to spin and spin, like those things that clean your rocks also, right? It's going to spin and spin and spin. And as it's spinning, it's not a nice smooth rock. It's actually jagged, and it's going to cause more inflammation and more risk for fistula and more risk for perforation. And if you perforate out into the peritoneum, what symptoms will you get? Peritonitis. What's peritonitis symptoms? So rigid, distended abdomen, extremely painful, board-like, right? So again, peritonitis is a complication of several GI disorders. So when you write down a complication for a GI disorder, a peritonitis, that you just copy and paste what you know about peritonitis. It's really bad. They need surgery, right? What else do you do about peritonitis? Or what does it look like actually? Or sorry, lab-wise, what does it look like? The white count will go up, right? Vital signs might start changing, might get a fever, right? These are all signs of infection that can develop. So that's how diverticulitis happens. And it's so inflamed that the vessels are actually not cauterized, but are so inflamed that they're pinched off. You don't really get bleeding with diverticulitis. If you do, it's rare. We're not going to talk about the exceptions. We're going to talk more about what's most common with these diseases. So, if you do have this diverticulitis and it causes perforation, it's causing vital sign changes, it's causing peritoneal symptoms, then we need to get surgery involved to fix it. And what are they going to do? They're going to take out that piece that's perforated, right? They're going to resect it. They're going to take it out and either anastomose the ends, but usually they won't. They'll anastomose one of the ends to the abdominal wall. And what is that called? A colostomy, right? So diverticulosis versus diverticulitis. Which one bleeds? The diverticulosis bleeds, right? All right, so symptoms of diverticulitis, right? So we have left lower quadrant pain. Why left lower quadrant? Because that's where the sigmoid is, right? And that's the most common place for diverticulum. Okay? We get a SIRS response, and we'll talk about SIRS with sepsis after your first exam. You'll be dead after your first exam. You won't be able to hear me anyways. So right now I'm going to tell you about SIRS. All right, so it's a systemic inflammatory response. It's due to inflammation somewhere in the body, right? It's gone systemic, right? It's a huge deal, right? And peritonitis is a huge deal, right? It's a lot of bacteria pouring into the gut. So it's going to cause a widespread inflammatory response. And basically what you get from that is an SNS response. And also you get a fever and white counts. Those things go up when you have a severe infection, right? So abdominal X-ray and CT scan, we can see the free air like we talked about before. CT scan will show where the perforation is, so they can know surgically that they have to go in and fix that piece, right? They can see where there's a fistula. They can see diagnostically what's going on, right? And that's what told you to call the doctor and tell them they need that. You told them they have the symptoms there. They have the SIRS response, got a fever. They have a rigid board-like abdomen. They have diffuse pain. Those are signs of a diverticulitis on your hand, especially if you have which quadrant? Left lower quadrant, right? What else? We've got, look out for signs of complications besides perforation, peritonitis. They could have fistulas, right? So they have UTI symptoms. They have vaginal symptoms, all right? They could get bowel obstruction due to scarring that can happen there. These are all things that can happen from diverticulitis, right? So diverticulitis is the one we put it in green because it's gooey and infectious, right? And that fecal lith in the middle is just spinning and spinning and spinning, and it's tearing up the sides there, causing localized inflammation. It can tear it up enough to cause a perforation or fistula, right? And then whereas diverticulosis is where it's stretching and outpouching. It's stretching so much they can stretch the vessels apart and cause a bleed to occur. Okay, so what's the treatment for both? So in red is our bleedy one, right? That's our diverticulosis, right? So they have GI bleed. Are they going to have coffee ground emesis? Impossible. Right? How is it going to make its way all the way up 30 feet of bowel into the stomach to throw up, right? It's going to be hematochezia, okay? Even even melena, it's only going 12 inches, right? It's not going to be in the bowel for an hour or so to make it melanotic, right? So GI bleed, you're going to have hematochezia, right? They're going to do, what are they going to do? Colonoscopy. Go in there, they can cauterize it. They can go and fix it right away, right? They can put a little coiling in there. They can clot it off, basically. If they can't control the bleeding, they have to go to surgery and resect that part of the bowel, right? And diverticulitis. Diverticulitis is, you may need surgery if there's perforation or a fistula. If not, it's just they just try antibiotics and you're going to monitor them. So what are you going to monitor them for? For UTI, for vaginal infection, for peritonitis, for those complications, right? Will you do a colonoscopy? You do not, because it's all inflamed and it's under high pressure in there. You can pop the sigmoid guaranteed if you do a colonoscopy, right? They will do one about 6 to 8 weeks, but acutely right there where they're inflamed, we're not going to be doing a colonoscopy. All right, it's going to make a big frowny face on the GI doctors. They'll scope you if you volunteer. Anyways, diverticulosis, diverticulitis. So the difference is which one bleeds again? Is diverticulosis, right? They're both due to increased abdominal pressure, and then one led to the other. Which one happened first? Diverticulosis happened first. It laid the groundwork. It made a little outpouching, and then that caused the bleeding. And then we have a fecalith that can develop. You may see in some like practice questions, or I'm not sure if the book mentions it, but it's a myth about seeds. Like people with diverticulosis can't eat seeds or nuts. That's completely debunked. That's not going to cause the fecalith, right? It's your own stool will do it. So yeah, so you can eat seeds while we have diverticulosis. All right, that's actually going to be increased fiber. It's going to actually be great. It's actually be solving the problem than making it worse. Okay, so you see in the bottom right there, we might have to take out a piece of the sigmoid, and one piece will go to the bowel wall, the other piece will be sewn up until it repairs and it's no longer infectious, and then we can sew them back together in a month or two. Okay, and then what else? We can cauterize with a scope, right? That's a diverticulosis. Can you scope someone with a diverticulosis? Yes, right? Diverticulitis, you cannot. Diverticulosis is just, there's not increased pressure, it's just bleeding because it's been stretched out.